Okay, I am going to make a start now. We've still got people gradually joining us. I can see the number of participants going up, but I think it's important that we give ourselves enough time for today's session. So firstly, I'm going to introduce myself. I am Saffron Cordery, and I am the Deputy Chief Executive here at NHS Providers. And I'm really delighted to welcome you to today's session. Just want to let you know that the session is being recorded, and that's so that others have access to it afterwards. But we think every delegate should know that the session is being recorded. And for those of you who don't know who NHS Providers is, we are the membership organisation for trusts and foundation trusts. Our role is to support our members to deliver high quality, patient-focused care by enabling them to learn from each other, acting as public voice and helping to shape the system in which they operate. And I think, you know, in terms of what NHS Providers has been focused on is been really around the race equality agenda, and this programme has really been about how we support board leaderships in terms of how they learn and chart their way through all of the issues that really surround race equality. And in today's session, we are going to look at how trust leaders and NHS leaders are using innovation to address elective backlog, looking at issues around systemic racism, structural racism within accessing healthcare, and how looking at analysing waiting lists by deprivation and ethnicity can start to overcome some of that. We have developed this session using insights from white and ethnic minority trust leaders who've looked at the kind of three key areas that they believe are needed to tackle to bring about meaningful change on race equality. And these are around hearts and minds change, really getting people on side. It's about giving leaders the confidence and capability to act through evidence that we know works, and also asking leaders to take accountability themselves to embed race equality at the heart of the board's business. Our speakers today, who we're delighted to welcome, are Professor Kiran Patel, who is Chief Medical Officer and Consultant Cardiologist, and also Deputy Chief Executive at University Hospitals Coventry and Warwickshire. And we've also got joining us in due course for their session, Dr. Ruw Abeyratne, who is Director of Health Inequality and Inclusion at University Hospitals Leicester. So if we could just go on to the housekeeping slide, bombard you with information there, but the things you really need to know are that all of the speakers will keep their cameras on. If you lose connection, then please do rejoin using the link, and do keep your microphone muted during presentations, because we know lots of background noise can come in and it does distract from the presentations. Please do chat to us throughout this event, ask us questions using the chat function. And if you want to ask a question outside of the chat, pose it yourself, then do use the raise hand function and we can bring you in. And really importantly, any questions that are left unanswered today because we don't have time or we don't have the answer to hand, we will come back to you and answer them. So please feel free to ask your questions of us. So without further ado, I'm now going to hand over to Professor Kiran Patel, who will take us through his organisation's approach to tackling health inequalities, particularly through their waiting list initiative. As I said earlier, we will take questions after this session as well as have a more general conversation. So over to you, Kiran. I'm really looking forward to hearing from you.
Yeah, thank you, Saffron. And it's a real pleasure to be here. Thank you for the invitation. I guess I'm going to compress probably three and a half years worth of work into 20 minutes or so, and take you through a really quick tour of how we were passionate about inequalities at the outset as an acute provider, but really didn't know exactly how we could play a role in that. But having come from NHS England, where I led some of the public health work, I thought, what can we do as an acute provider in this field? And the pandemic offered some fantastic opportunities. If I could flick on to the next slide. I guess the first thing is just a statement to say we often don't realize that it's the inequalities in health that should concern us, not the inequalities in illness, because when you're ill, you're ill. But we just have illnesses that come upon us at different ages and stages of life. So by the time you get to an acute provider, of course, you'll get all the care that you need, and we do our best for everybody. But actually, it's when you get there that matters. And what we want is people to live a healthy life for as long as possible and as free as possible. And it shouldn't matter what age, gender, sex, race you are, but you should have that health with you. And it's the inequalities in health that should worry us. But in terms of what drives that, the next slide will show us that essentially since Dahlgren and White had published their model of social determinants back in the 90s, we know what drives your health outcome. So as a health provider, only 10 to 15% of your health outcome is dictated by the care that you're given. Actually, 80 to 85% of your health outcome is predetermined. And I say that because actually some of it is genetically predetermined. So you may well have cystic fibrosis and you're born with that genetic predisposition and you suffer with it. But actually your upbringing, the deprivation that one grows up in, means that you're exposed to different diets, different levels of exercise, access to green areas to exercise. And then of course your race is important because actually the degree to which you access healthcare is dictated to by race. And there is a huge amount of literature out there. And just this morning on Radio 4, I was listening to Don Rockenden talking about maternal outcomes and the difference by race. And actually we've known for 40 years the statistics that Black women will have a more adverse outcome than white women. And we've seen that data again and again, published year upon year. And if I were to flick forward, to add to the fact that we know what drives health outcomes and social determinants of health, this is just a sample of the reports that we've had back since 1980, where I went back to. And I put it to you that each of these reports tells us the same thing. It tells us what drives health inequality. We know that income, education, deprivation, housing all factor in. And in fact, if we go back to the 1858 report from the first Chief Medical Officer's report, it told us very similar things. So we know, and we're very good at describing what drives health outcomes. But I put it to you that actually we're less good at knowing the interventions that we need to invoke in order to improve things in terms of health outcomes. So I'll go on to the next slide, really. We know what the markers are for health inequality: adverse childhood experiences, educational attainment, alcohol abuse, drug abuse. I could go on through that entire list in front of you, but we know the markers. So these should be the signals that bring forward what people are going to be predisposed to. But I add to this one, race, and I purposefully haven't put it on the slide because the moment you put race onto a slide, people's attention focuses onto it. And you get half an audience who are absolutely committed and know what it means, the other half who think, here we go again. And I think the here we go again camp probably need to sit down and think, because they're probably responsible for that maternal outcome being the same over the last 3 decades and doing nothing about it. So we need to look more closely, but actually there are some little touch papers, some signals and areas where we can pick up individuals who are prone to health inequality. I'll go on to the next slide, please. So we know that health access is relevant. So if you're going to drive a health outcome, the first thing you need is to have good access to healthcare, be that urgent or elective care. And I remember one of the most worrying reports I read back in 2015 was a report from the Midlands and Lancashire Commissioning Support Unit, who looked at access to elective care and urgent care. And what they found was a social gradient in access to healthcare. So more affluent people were more likely to achieve access to elective care than poorer people. Poorer people were more likely to end up in the emergency department. And these were factual statistics that I saw, and it was really worrying. And when we looked behind that data to say, why does that happen? Of course, it's because more deprived individuals tend to work. They can't get to the hospital in a 9 to 5 appointment. They can't get transport. They can't stop being a carer. They have to pick up children. And of course, the more affluent you are, the more likely you are to be able to compromise that and get somebody else to do those chores so you can access your appointment, or dare I say, even seek private healthcare for elective care. And we're seeing that play out in front of us today. And the consequence of that access inequity means that we have delayed diagnoses. So we know that South Asians are diagnosed with diabetes 10 years earlier. We know that cancer outcomes are at a much later stage in more deprived populations. We know that prostate cancer is much more aggressive in Black males. So there is a huge literature out there which tells us about the racial inequality and social inequality in terms of delayed diagnosis. And the pandemic has really brought a lot of that home. Next slide, please. So we're at a point and a juncture in time where actually we can think about the benefits of centralization versus devolution. And I put it to you that actually devolution isn't always a good thing. Even though Manchester has made some great headway into health inequalities, the USA has much more stark inequalities driven by devolution than we have it. So it has to be managed. We know that austerity will hit the vulnerable most hard. And actually in this day and age today, where we have recurrent rolling strikes and a growing elective care backlog, it is the more deprived population that is going to be hit the hardest. So we need to think hard about how we manage that level of unrest politically. And of course, any form of market regulation or liberty has a greater impact on more deprived individuals. So even the failure to tackle tobacco regulation means that not only do poorer people smoke and consume alternative tobacco means, but actually if you're poorer and from an ethnic background, you are more likely to take in alternative forms of tobacco, such as snorting, rubbing it into your skin, betel nut, and all these drive health inequalities. So actually you compound the effect of socioeconomic deprivation with ethnicity and race. Next slide, please. So how do we think about health inequalities, or how should we think about them? Well, we should see health as an asset, first of all. We need to start leveling up and not just say that we need to wait several generations for health to level up. We can do it within a generation, as Michael Marmot has said. And we should see illness as a cost, not in isolation, but as a failure to invest across the whole health and social care spectrum. So our failure to have good public health intervention measures that is equitable to all should be seen as a failure for all of us, not just healthcare services. And of course, there are healthy places, and I won't go into that today. But the next slide will tell us about the challenge we have at the moment, as I see it. I think we do have to take on combating health inequalities, because unless we do, the gradient is going to increase. We do need to be giving ICSs the solutions that are available to us and thinking about how we couple prevention and provision, and thereby generate genuine population health intervention measures. But all of this has to be coupled to good access to our services locally. Now I'm going to take you on the next slide to the number 10 bus route in Coventry. And every city in the country will have a similar number 10 bus route, which tells us about life expectancy across a city. And there is a 10-year differential in life expectancy in Coventry along the number 10 bus route. And the same will be seen in Leicester, Birmingham, Glasgow, London. So this data has existed for years and years, if not decades and decades. And of course, the pandemic has shown us that our elective care backlog is growing. And these are two very different statistics, which we wouldn't have conventionally pulled together. But actually, the pandemic made us do that. And the next slide will show us that I think one of the most fantastic things that happened was the desire to recover our elective care inclusively. And it was fantastic to see that come out, probably about 18 months after we'd been through the pandemic. So back in April 2020, in wave one of the pandemic, we were all told to stop elective activity. And I was sitting here as interim chief exec because Andy, my chief exec, was off at the Department of Health doing test and trace. But actually we were told to stop elective activity. And I remember picking up that report from the Commissioning Support Unit about socioeconomic gradients. And I asked our analytics team to say, give me the socioeconomic gradient and ethnicity in terms of access to our elective care and urgent care at the moment. And I was alarmed because the gradients were so steep. I was seeing almost exclusively access within the ED was from more deprived postcodes or from ethnic populations. And I was seeing that actually people accessing the elective care that we had were almost exclusively from the higher socioeconomic spectrum in terms of affluence. And the pandemic made those gradients worse. And at that time, I remember writing an article in the BNJ blog saying, look, we've got to be really careful. We're going to see a really significant health inequality as we recover from the pandemic. And a report that I'd read in New Scientist from 1955 told us that was going to happen. So I used that to say we were going to continue elective care. And in fact, we didn't stop it in Coventry. And it's one of the reasons we came out with less of a backlog. So we continued elective care. And on top of that, we started to think about how we'd reduce health inequality. Because at the same time, we were seeing that more BME patients were coming in and dying from COVID. And of course, we all read about the unequal impact of COVID and how it shone a light on health inequalities with respect to race. And those were just some of the reports that I'll allude to and refer to. So the next slide will show us that socioeconomic gradient, just as a sample of access to elective care and emergencies. And you can see a very clear linear gradient. And that gradient got worse during the pandemic, which is why we started to think about how we couple elective recovery with access to healthcare. And we started using postcode and ethnicity for that access. Next slide, please. In addition to that, of course, we see patients who don't attend healthcare. And again, there is a socioeconomic and ethnic gradient to that. And what do we do normally? We tell people that 3 strikes and you're out. You don't get another appointment. Actually, we started proactively calling patients and saying, why did you not attend your appointment? And we got the usual stories of poor transport, unable to leave work, etc. And one of the most sad complaints or letters I had during the pandemic was of a lady who said it was really great that we were starting to provide digital and virtual consultations for her outpatient appointments, but did I realize that she'd had to go out and buy a mobile phone and a top-up voucher, which cost her £20 of her £29 weekly allowance. And by the time she'd got through, her allowance had run out, so she couldn't attend the appointment. And it made me sit there quite sad at the fact that we'd actually made somebody poorer and deprived them of healthcare by doing something which we intuitively thought was the right thing to do in terms of digital outpatient appointments. So you've got to guard against digital illiteracy. So the next slide will show us that actually, if we did nothing as we recovered from the pandemic, inequalities in health outcome would get worse. And across the country, I think this is happening unless we are restoring inclusively in pockets. So our strategy, as detailed on the next slide, showed us that we had to cover 3 angles. First of all, we had to proactively case find where patients weren't coming from. So we used our joint strategic needs assessment from the public health consultant who works with us to say, where should we target GP surgeries and localities where we know patients aren't coming for their care. The second was uptake and prioritization, which I'll talk to you about in a bit more detail today, in terms of how we could prioritize access to healthcare based upon health outcomes, not just waiting times. And the third was really to make sure that we harnessed experience and outcomes so that we guarded against issues such as digital illiteracy and digital exclusion. Next slide, please. So restoration, we did. I'm proud to say we did with inclusivity at heart. We wanted to make sure not only did we not widen inequality, but how could we restore it by using postcode, ethnicity, and other factors that drive outcome. In addition, each of our letters had a QR code so that patients could, before they came to hospital, access a whole heap of prevention services, including questions about domestic violence or dementia. So we were coupling prevention at scale to outpatient provision. And before people ask, actually, if you couldn't access a QR code or know how to operate it, when we have patients who come to clinic, they get taken through an iPad if they hadn't already accessed the tool, should they wish. Now, the next slide will tell us the focus of my talk, really, which is about waiting lists and how we manage them. Now, we always use the RTT metric, the referral to treatment, as a driver for how we provide services. And I put it to you that using RTT in isolation widens health inequality. And to explain that, I'll use 2 examples of avatars. William from Warwick, who is a solicitor who's had a growing great upbringing, very affluent, has had a great diet throughout childhood, played lots of sport. And of course, he's free of any comorbidity, but gets a bit of hip pain sitting behind his desk one day during the pandemic. And he sees his GP, gets access to good physiotherapy, but his hip pain still persists. And therefore, he gets onto the 18-week pathway very, very early on in his disease pathway. Now, he then gets referred, flies through surgery and recovers, and is back at his desk 2 days after hip surgery working. Compare and contrast that with Norman from Nuneaton, who has a very deprived upbringing. He has a poor diet, so by the time he's 20 years old, he's diabetic, hypertensive, he smokes. But because he's on a 0 hours contract, he can't afford to stop working. So he will continue with his hip pain until it becomes unbearable and he cannot work any longer. So by the time his GP puts him on the 18-week pathway, his hip osteoarthritis is much more advanced. And when he goes into surgery, his comorbidities mean that he has a stormy recovery period, and he may well not recover sufficiently in order to get back to his 0 hours contract work. And of course, if Norman is the sole breadwinner in his family, then he may not get back to work and the family spirals downwards. And we saw this pattern of widening inequality throughout the pandemic. So both of these individuals have had an 18-week pathway, but we've undertaken a disservice in terms of getting Norman treated quicker to get the same outcome as William from Warwick. Next slide, please. So when I talked to our clinicians during the pandemic, we said, what drives your health outcomes? And we found that there were many factors. If we just flick on, we know the clinical factors which drive health outcomes. If you just click on, and again, there are a whole bunch of clinical factors that drive health outcomes, be it in cardiac surgery or hip osteoarthritis, and we know what they are. And we started listing those, and we coupled them to the operational factors that drive health outcomes, such as time on a waiting list or repeated presentations to the ED department. And we put all of those into a tool, and we've turned it into software that helps to schedule care based upon predicted outcome of the patient. So we have developed a way of providing elective recovery that is based upon health outcome, not just on waiting time alone. And of course, if we had conditions like diabetes in there or hypertension, it brings to the fore the impact of race on health outcomes. So next slide, please. And we'll just flick on. I'll just give you two avatars, patient A and patient B, who are both waiting for the same care. And traditionally, we'd schedule patient B because they've been waiting longer. But if I showed you the next slide, we delve behind the drivers, then we'll start to see that patient A, although he's only waited 15 weeks, has lots of comorbidity. It's from a deprived area, it's from an ethnic group with poor outcome and high risk of diabetes, has been in and out of A&E, compared to patient B, who's a smoker but nothing else. So patient A is going to have a much more adverse outcome than B. And using our algorithm based upon outcome, A would get scheduled before B, which goes contrary to the way in which we've traditionally delivered healthcare. But of course, both of these will get the NHS constitutional standards. So the next slide will show you how the demographic of a waiting list changes, away from those who have waited longest, getting care earlier, to those who will get the best health outcome, getting care earlier. So we best utilize the resources that we have. And if we just click on every day, we can see a waiting list, which is produced in our trust, which tells us exactly how to schedule patients. So if we have a gap coming up tomorrow in theatre, we know exactly which patient to call overnight to get into that slot based upon the next most needful patient, not just random calling. Next slide, please. So overall, this shows you what's happened to our orthopedic waiting list by scheduling in the way that we do to restore inequality. What we've done is gone from a point in April 2021 where we had a differential in access inequity of about 6 weeks to one where the waiting time for everybody has improved, but actually the gap has narrowed as well. So everybody's health outcome in terms of health access has improved, and we've reduced the inequity gap. And we've done this across many specialties now as we apply the tool across the spectrum. Next slide, please. So you might ask what patients and citizens think about this, because of course, being British, we like to wait, and we like to wait equally, don't we? and we probably wouldn't be happy if somebody jumped in front of us in the queue. So I commissioned Ipsos Mori to do some independent work with citizens across Coventry and Warwickshire, and this report is available online. And it was a fascinating exercise. They did a great piece of work, which told us that in the main, most people understood why somebody would leapfrog them in the queue if they were suffering more or they had a greater healthcare need. But there were still pockets of society who thought, actually, over my dead body, I want to wait the same as everybody else. It's somebody else's fault if they decide to smoke or become obese or drink more or have high blood pressure. So there is a range of public opinion out there. I don't doubt that. But what we must do is make sure everybody receives the NHS constitutional standards. But in addition to that, I think you can reduce health inequality within that provision. Next slide. So we've moved on, and because we've been working on this for a couple of years, talking at environments just like today, people have asked us whether they can adopt the approach. And the next slide will show you that we have started diffusion of what we're doing. We've worked with a series of pilot sites. We've worked with Leeds and Oxford as early adopters. And we have a pipeline of about 50 systems and organizations across the country who want to use data based upon health outcome, ethnicity, and race in order to schedule care to get better population outcomes and needs. And we're not going to stop there. The next slide will show us about the journey ahead as well, because I think we could do better. I think, hopefully we will end RTT as the single driver for scheduling healthcare, but actually we'll have a scheduling system that has health outcomes at its heart. So I think we can hereby couple the NHS outcomes framework with the operational framework in the NHS. I'd like to see a system, and in fact, we have now adopted our software so that GPs can automatically tell us how patient conditions are changing whilst they're waiting on our waiting list, be it 52 weeks or 78 weeks. And if a patient's getting worse, the GP can change the position of that patient on the waiting list. And ultimately, why should we not empower patients to be able to do the same? Of course, if we can guard against gaming of the system, why can't we trust patients to tell us when their condition gets worse or indeed gets better, and they may not even need their cab? So better use of capacity across the NHS. And then, of course, we can take this to another degree by coupling it to social value judgments. So within our software tool, you can capture the employment status of a patient, or you can capture whether a child is missing school or not because of want of healthcare. And by doing that, we can genuinely start to tackle some of the drivers of social determinants of health outcomes. Because if we can get people back to work and improve their income and status, of course, their lifespan and health is going to be better. If we can stop children having an educational adverse impact for wanting healthcare, of course, we're sowing the seeds of better health throughout their lives. So we can start to use these factors that drive health outcomes to schedule healthcare. So I think the next slide is my penultimate. I've shown that during the pandemic, it was fantastic. In the midst of every crisis, that was a great opportunity. And I think we wouldn't have done this had it not been for the pandemic. And I think the next slide is my last, Saffron. So thank you very much for listening.
Thank you so much, Kiran. That really was so rich, and you managed to get through so much material there in the time that you had. I wondered if I'm going to invite any questions that people have that they want to ask, but in the meantime, I just wondered if we could kind of drive into or drill into that element of getting colleagues on side with this approach, getting the community on side with this approach, because I can imagine the level of abreaction there might have been, and I just wonder what kind of tools and persuasion you used with particularly I suppose firstly your board colleagues, but then your wider staff group, as thinking about that.
Yeah, it's a good question, Saffron. So I think when the NHS initially came out saying segregate your waiting list by postcode and ethnicity, I saw abreaction from the clinicians saying, for example, why should a BME male waiting for hip surgery be prioritised over a white male? Because ethnicity in that situation doesn't confer an adverse health outcome. Whereas, of course, the opposite applies if you're talking about prostate cancer or coronary artery bypass grafting. So making this evidence-based and clinical, I think, made it easy to sell. And in fact, the clinicians were then driving this, saying, actually, this is absolutely the right thing to do. Use the clinical factors that drive health outcome, but not just the political whim.
Excellent, thank you. I'm going to ask and see if there are any questions either in the chat box or from the audience. I can't see any raised hands at the moment. Do we have any further questions?
We have a few. We have one from V. Mazonde.
Okay. Hi there. Thank you very much for your presentation. That was very informative. I am currently working with EPUT, which is Essex Foundation Trust, and we're in mental health. So I wondered if a similar exercise is transferable at all to mental health.
Yeah, the simple answer is yes. So we're working with our mental health trust locally in Coventry, who have adopted the tool, and they're telling us about outcomes. So they're using it to schedule in areas like eating disorders or schizophrenia, where of course ethnicity does play a part. So yes.
Great, thank you very much. So I am very much more interested in also connecting and understanding their findings as well. So will the so to the host or yourself, will you be organizing and arranging a session on mental health specifically? Because I'm conscious that this focused on acute care.
I think we can come back to you definitely on that one, and we'll work through the logistics of that. But I think it's, you know, making sure that we broaden this approach out, I think would stop a kind of a double inequality from happening there, because we know how marginalized often mental health care is within the kind of the broader focus of the NHS, often on different services. So I think it's a really well-made point, and we might come back to you, Kiran, to give us some pointers on that. I'm just gonna, there's a couple of questions in the chat. So the first one from Jane Phoenix, who says she'd like to know more about the impact about how additional factors are taken into account, especially mental health and learning disability, and noting few people are one aspect. So an individual may have a range of factors, e.g. deprived, severe MI, and unable to travel. So kind of how do you factor in all of those additional factors?
Yeah, so the software we've developed weights each of these factors, and we started off by weighting them equally. But of course, you can tailor how much weighting you put behind each of these. So, for example, somebody with a mental health illness and cardiovascular disease, it would have a synergistic effect, so a greater weighting to help prioritize the care in that case. So it's dynamic. Yeah.
Thank you. And I'm just going to take a question now from John Geeve. Sorry, I can't see the raised hands, but I'm being told that, John, you have your hand up.
Yeah, thanks. Well, I was very impressed by your account, and particularly how you'd taken account of the sort of interconnection of different factors in individual cases in order to come up with the order. And I was very, very impressed that you've done it in a win-win way. So everyone was getting lower waiting times. And you said, of course, everyone gets NHS constitutional standards, but as you know, that is very far from being the case at the moment in large parts of the country, but very well done in Coventry. The question I had really was how far this is about ordering, if you like, the people who are in the system coming from their GPs. How significant is that, do you think, compared to putting your effort into outreach from the GPs, if you like? So in other words, sort of two reasons why people may have worse health outcomes. One is they arrive, they get discriminated against when they arrive. The other is they arrive late. And you can sort of catch them when they come in if they're late arrivals, but how do you bring them in earlier?
Yeah, John, that's a really good point. And in fact, when we had Panorama filming us during the pandemic, they filmed a scene whereby we were calling around at random to GPs and patients who could come in and fill a slot. That was very precious. And in addition, the secretaries were being badgered by either affluent patients directly or their GPs because they knew how to badger the system and get in earlier. And we thought we wanted to drive that out of the system. So ordering the waiting list based upon need was absolutely the right thing to do. And it took away the secretaries being badgered and adverse health-seeking behaviour, which led to differentials in terms of access of healthcare. And coupling it to what you're saying, John, using the needs assessment meant we knew which practices to target to say, which patients are you referring to us? Please let us have them so we can put them into our queue and prioritise them when we can. But fundamentally, delivering the constitutional standard is a must. Otherwise, people would be waiting longer and longer, and we'd be being told off by NHS England.
Thank you. I'm going to wrap up this session now, and I'm going to introduce our next speaker in a moment. But just to say, any additional questions that weren't answered there, we've got time for collective Q&A after the next speaker has presented. So we will get the opportunity to pick up some further questions there. So I am going to move on now and introduce Dr. Ruw Abeyratne, who is Director of Health Equality and Inclusion at University Hospitals of Leicester NHS Trust. Ruw, you're very welcome, and over to you.
Good afternoon. Thank you very much. I'm sorry that I couldn't join from the beginning of the session. I was reporting to our Health Equity Committee that reports up to our Integrated Care Board, our quarterly update. So I'm sorry that I was late, but I caught the end of Kiran's excellent presentation. So I'm going to talk to you a little bit about the work that we're doing at UHL, specifically thinking about ethnicity, but also some of the intersectionality that's already been discussed. If I could have the next slide, please. So I'm going to talk around our approach to health inequality and focus it on some work that you may well already have heard of around non-attendance at our planned care. What I'm going to try and do is take you through what I think is a developing strategy and approach to this at UHL. And I'm intentionally using the word developing because I think we're on a journey. So I've been at UHL in this post since June of last year, but I like to tell people I didn't start until August because I took an extended summer holiday. So over the past 8 months, what I think we have started to define is a UHL way of approaching health inequalities. The framework that we hang all of our work off is around the Core 20+5 framework that NHS England have developed. And we have found it incredibly helpful to have the Core 20+5 framework there, and we keep rooting ourselves in that, whilst also trying to tailor the work that we're doing to our local population and the needs of our organisation as well. So as I take you through the case study of the non-attendance work that we have been doing around ethnicity and deprivation, I will tackle this in 5 ways. So we will talk about data and how we've used data. We will talk about improvement, people, and what I mean when I talk about people, our approach to learning, and then the importance of culture. So if I could have the next slide, please. Okay. So the data is really important in terms of understanding what the local context and the local problem is. And it sounds really obvious when you say it out loud, but even this morning, the BBC, the first thing I saw on the BBC app was a conversation about differential experiences and mortality for pregnant and delivering mothers from Black and Asian ethnic minority groups. So that's a blanket statement about the national context, but what does that mean for me day to day? And more importantly, what does that mean for the women of Leicester, Leicestershire and Rutland, which is the system that I work in? So what we've tried to do is make sure that when we're talking about data, what we're doing it is in the context of our local population. The non-attendance pilot came from, first of all, the request that we disaggregate our data and our waiting lists by ethnicity and deprivation, but also then factoring in the Core 20+5 framework. What I've tried to do on this slide is just give you an indication of the importance of recognizing the intersectionality that was asked about in the previous Q&A. So I took two specialties to share with you. So our gynae-oncology waiting list and our breast care waiting lists. So when we look at this purely from an ethnicity picture, we get a picture of actually the vast majority of our appointments are still occupied by white British individuals. And their non-attendance rate, as you can see, is around 5% all for both specialties. But when we go back through the ethnicity data, what we can see is although the absolute number of appointments is lower, the proportion of non-attendance is higher for our ethnic minorities. But then when we factor in deprivation, so if you look at the bottom two graphs, actually the impact of this across more deprived populations is also visible. So if we only target ethnicity, then we miss some of the picture for other patients. And this is a really tricky problem. So in a previous national webinar that I was presenting at, the exact question was, why are we focusing on race? Why are we talking only about ethnicity? We need to be talking about other protected characteristics. And my answer to that question, it may not be the completely right answer, but the stance that I took was, there is a clear problem when we talk about race and ethnicity, and we have to do something about it. If we pay attention to and regard to the intersectionality of other characteristics, then we will develop and we will learn, but we have to start with where we can see there is a problem. And clearly for us in Leicester, Leicestershire and Rutland, there is a problem centred around ethnicity and deprivation. If I could have the next slide, please. So once we've got the data, what do we do with that and how do we use that? So for me, data is an enabler. It gives us information, and actually the joy and the beauty of the data is helping us to define a specific problem. So when we put that together with Core 20+5 as a framework, what we were able to clearly see was there was a huge need within our respiratory services for doing something to tackle non-attendance rates. And what is important about non-attendance, and I think this is a really important concept. So when we talk about non-attendance, there are different aspects to it. So for me, there is the patient's story. So what is the impact of not attending the appointment that you have been sent or has been allocated to you? But then there is also the provider aspect. So what is the impact for the service provider, for the clinicians, for the future of the waiting list? And I think to think of it in those two different ways is really helpful. So what we're trying to do here is improve efficiency and productivity. What we're trying to do here is make sure that the patient is in the right place at the right time for the service that matters, that they need access to most of all. In our respiratory services, we were able to demonstrate that we had a significant non-attendance rate, and respiratory, much like many other trusts across the country, is one of our biggest services. What we started with was a presupposition about what we thought the solution to this problem might be. And so our original pilot in this piece of work started with contacting patients in the most 10% deprived populations to remind them of their appointment and to offer support to attend our appointments. That work started in just before the summer last year, and we were able to demonstrate a significant improvement in non-attendance. So in the worst case scenarios, around 50% down to around 8% on average. The important bit about that for me is clearly 8% is still too much, but what we were able to demonstrate is that we were able to eliminate the differential in outpatient attendance. That is, our trust average is around 8%, and we were able to bring the non-attendance for IMD1 down to 8%. If I could have the next slide, please. Thank you. So taking an improvement approach to this work is really helpful and important. When I first started in this role, one of the first questions that I asked about this piece of work was, what is our plan to sustain it and what is our plan to scale it? And this is not a criticism of the people who originated this project, but at that time there wasn't a plan to scale and sustain. And so what we have tried to focus on over the past 8 months is building a narrative for how we do scale and sustain this work. The first part of that was taking time to pause and reflect. And I think that's really difficult when you've shown progress in something. taking the time to hit pause and say, actually, we need to learn from this as well at the same time, and recognizing that most people are doing other things as well. But we did just that in September last year, hit pause and took some time to reflect as a team on what we had learned so far. And it was very interesting. So initially we had started off by using volunteers to contact patients, and what they very clearly and very quickly described were what they called cultural barriers. So some of that was around language barriers, and we found that requests for help sometimes referred to how to organise an interpreter or how translation services would work, and ensuring that we could arrange that. But there was also a narrative around, as a volunteer working for this trust, I don't understand the context that patients are living in. And so it's very difficult for me to then offer support that is meaningful to those patients. And that was a real wake-up call to us. First of all, we had placed people in a position without giving them the tools that they needed to help people. And second of all, we hadn't asked patients what it is that they would need when we made contact. We'd done it the other way around. We'd gone to them and offered our support without engaging with them first to think about what are the challenges that we're going to hear about. So still really important learning. And actually what we'd recognized also was that our volunteers were feeling uncomfortable about limiting the work that we were doing to one specialty, because there was a clear improvement and a clear impact for those patients who we were calling. So as an outcome from that, we've changed the way we've done things. So we no longer ask for volunteers, we are asking for bank staff who are paid and then who go through a process of training and understanding in terms of the script that we're using. And we've also rolled out the work to all specialties, for the most deprived patients, because people were uncomfortable with thinking that we had focused on one specialty. So where there were some challenges, hopefully what I've demonstrated is the time to pause and reflect and improve has then led to some learning and development. And I think what we've described there is not a very rapid, but a PDSA cycle. So we then embarked on a second round of this work with our most recent review happening just a few weeks ago. We did have to hit pause over the winter because of operational pressures, but I think that was not without expectation. And we continue to see a very positive impact. So we have seen a deterioration in the non-attendance to 10% where it was previously 8%. But what's still very clear to us is that when we aren't making contact with patients, the non-attendance rate is significantly higher. And so I think what that does is demonstrate there is something about the human contact, but then there is also something about how do we ensure that we're reaching that 16%? Because arguably they are the ones who will need us most. Very excitingly, and I'm really pleased to be able to share with you that we have managed to secure funding for this work through to the end of this financial year. And the reason that that is important is because previously I spoke about sustaining and scaling. So the scale part of this work is really, really important. And what we hadn't done is built into our plan for the initial pilot. How do we make this bigger? So when I talked about we've rolled it out across specialties, we didn't have a plan at the time for how we would fund that. So I felt I have had to go around begging and borrowing from various people to ensure that we've got the funding for that. Actually, what we've seen now is a change in mindset at operational level in terms of we have got to ensure that this is worked into our plan for the next 12 months so that we can continue this work, but we can continue the learning as well. And that's where I come to on the final bullet point. We have objectively demonstrated an improvement in terms of percentages of non-attendance for the most deprived patients who we care for. What we haven't done and what we need to do over the next few months is take a deep look at the qualitative information about what it is that patients are experiencing, what it is that we are needing to offer when we make contact. Anecdotally, we think that this relates to transport and access to our sites, interpretation and translation, and then wayfinding when patients are actually on our sites. And that is possibly unique to Leicester, but I suspect will apply to other trusts as well. But for me, because of the way this pilot has been set up, what we need to do is use that information and then be going out to communities to engage with them to find the solutions to those problems. Because what we hear is that when we don't do that, we don't get the solution right. And I'll come on to that. Next slide, please. So the third component of our 5 steps in how we're doing this is people. I was asked to deliver a board development session back in March about health inequalities. So this was to our trust board and our non-executive directors. And a big part of the conversation that we had was, do we know who the people that we're looking after are? Do we really know who this population is? So we spent a lot of time exploring the most recent census data and some health statistics. And actually, the reason that this is important is because we look after an incredibly diverse population. And I hesitated just before I say that, because I think there is an argument that many systems across the country are looking after diverse populations. It just depends on how we define diversity. But if I come back to the ask of this talk about ethnicity and different populations, that what I can explain to you is that in Leicester City, we have an ethnically diverse population. If we go out to Rutland, which is the blue part of the map that you can see on your screen, we have a much older population who are digitally excluded because they face some of the slowest broadband speeds in the country. And so when we think about solutions to non-attendance, we have to know which patients are not attending, and then we have to work with them to think about the solutions to that. Because if I offer a load of virtual appointments to people who are coming from Rutland, it's not going to be as helpful because I know that they've got slower broadband speeds and access to digital solutions are harder. And then furthermore, thinking about how we engage in those communities. A lot of the work that we have done within Leicester City has focused on the Asian population, and certainly Leicester itself doesn't have an ethnic majority any longer. We're one of the first plural cities. But actually what we saw from the data is that the Black African and the Black Caribbean community are particularly vulnerable to non-attendance. But when we go out to the Black African and the Black Caribbean community, the feedback that we get is quite different to the Asian community. And recently I was at a focus group where, and this was very powerful and stayed with me, one of the, some of the feedback that I received was, the NHS only comes to us in times of crisis. And so you want change to happen quickly, you want it to happen now, and you want to show results. Our community doesn't work at your pace. It was that bit that stood out to me. Our community doesn't work at your pace. You need to slow down. And I have very clearly been told there what the solution to some of our problems are. We are going too fast and we are asking too much, and we have a duty to listen to that. And so giving platform to those who don't have a voice and those who aren't able to advocate for themselves is really important, because what we're hearing consistently is, we don't trust that you're going to act on what we say. I'm speaking very quickly, and I'm speaking hopefully with fluency. I don't have all of the solutions to this. And part of the reason that I enjoy doing these webinars is because it's really helpful to hear how others are approaching this. But certainly we are engaging in a proactive and a slowered pace of how can we engage with our communities in a meaningful way. If I could take the next slide, please. Which comes on to our learning. So for us, our approach to health inequalities in Leicester, Leicestershire and Rutland has to be embedded and underpinned with learning. And some of that learning comes from the communities that I have talked about. Some of it comes from working in partnership with other organisations across research, academic partners and community partners. Again, Core 20+5 has been really helpful for connecting people and for signalling and signposting allies and champions. And actually developing our own network within that has been really important. So it's much easier now to reach out to people, or it's much more clear to reach out. So where we have our NHS Core 20+5 connectors, we have also developed relationships with local voluntary and community organisations. So just this afternoon, I was having a conversation with a charity that runs a food bank for the most deprived population within the city and doing some work with them. But again, and I think this is important, whilst we've shown some progress against our non-attendance rates for Black and minority ethnic groups from more deprived populations, in parallel, what we're having to do is slow down the pace of change to engage with some of the communities that we're needing to work with. And that's so important. And then I just wanted to draw to your attention the Institute of Healthcare Improvement Pursuing Equity programme. This is a programme that focuses on addressing health inequalities and racial injustice in healthcare, and it is run through the IHI. It's based in Boston. UHL is one of 8 organisations who are currently involved in the Pursuing Equity programme over the next 15 months, and we're the only European organisation. And I had the great privilege of going out to Boston in March with 2 colleagues for a 3-day intensive learning event to bring back to UHL. We have a broader team, a UHL Pursuing Equity team, and our experience is centred on developing a clinical project. So we have chosen to focus on the differential experience of Black and minority ethnic mothers, and in particular, late booking for antenatal care, recognising that inequalities start pre-conception and follow people through their whole life course. But the reason why this Pursuing Equity programme is really important to us and that we are fully engaged and committed to it is because it underpins, as I've previously mentioned, an improvement approach to this work. So we are embedding improvement science in our approach. It is giving us a strategic direction. It is holding us to account for the commitment that we are making, and this has come at a board level. And so actually what we are saying is we are committed to this in a very open and transparent way, and we will therefore be held to account for this by women and their babies over the next 15 months. So I'm really proud to be a part of it. It is a huge commitment and it's a huge responsibility, but I think that this is underpinning some of the difficult learning that we've got to do with our communities. And certainly the IHI, the learning that we undertook in March, referenced the historical relationship that communities have with our healthcare providers in today's context, which is very difficult to unpick. Thank you. For the next slide, please. And then our final pillar, if you like, is culture. So where I have talked about previously the challenge with communities and engaging with communities, our strong sense at UHL is that we have to talk about our workforce in the same conversation. So we are consistently told that colleagues have a differential experience based on various protected characteristics. And almost certainly, if discrimination is happening to our colleagues, it is happening to our patients, whether it is overt or whether people aren't clear about it and it is unconscious, although I use that phrase reluctantly. So we have to take the intel that we get from the RES data, the WDES, staff survey, freedom to speak up, and we have to map it to what we're seeing in our populations in terms of health inequalities. But the other reason that I think that this is important, and this goes back to Kiran's point about the NHS constitution, we underpin, or we should underpin, everything that we do with a sense of compassion. But when we have a workforce that is tired, exhausted, and experiences systemic barriers to delivering the care that it wants to and progressing personally, then what we're asking them to do is act on injustice in healthcare when they are depleted of the emotional reserve that they need to do that. And so actually, by working on culture, becoming a psychologically safe organisation, enabling people to develop and grow as professionals and individuals, what we actually do is create the headspace that we need for people to start talking about systemic barriers to accessing healthcare that drive differentials based on ethnicity and other protected characteristics. So culture is a huge part of what we do at UHL in terms of health inequalities, and I certainly work quite closely with our Chief People Officer and her team to start to bring the two together. Next slide, please. So what I hope I've done is summarised for you our approach to health inequalities, particularly with a focus on ethnicity and deprivation through these 5 pillars. I suspect if you ask me to come back in 6 or 12 months, there may be some refinement to some of this, but this is broadly how we're doing it. I don't think we've got it 100% right. I'm very sure that we will continue to learn and develop, but I do think we're showing progress, and I'm excited about what we can achieve, and I'm very happy to take any questions.
Thank you so much, Ruw. That's been an absolutely fascinating presentation, and I think having the two side by side, we're getting a really rounded picture of the different approaches that people can take. Now, what I'm going to do is, there are some specific questions for you that have come up in the chat, so I'm going to field those to you, but then I think we'll move into a broader Q&A around some of the themes that have come up throughout today's presentation. But an interesting question has come up in the chat from John Geeve, which is, why did you switch from volunteers to paid staff? Could the volunteers not be trained? So that interesting point around why use different people.
Yeah, it is interesting, and it was fascinating to hear it evolve. Essentially, we didn't feel that it was appropriate for us to put volunteers into a position where they felt obliged to be doing essentially what should be our business as usual. And part of the changing mindset is that this isn't additional, this should be core business. And so that's why we took the decision to move it away from a volunteer-based pilot to something that is requiring resource, and we have to commit to resourcing recurrently as the years go on. The other aspect of this is that some of the volunteers expressed that they were too uncomfortable to do it because of some of the difficult conversations they were having to have. And I think whilst we could have trained them in the same way that we've trained the bank staff are coming from professional spaces within our services already, whereas the volunteers are doing this, in their spare time, in addition to a job that isn't necessarily allied to healthcare. So we just felt it was the right thing to do, and moving towards a business as usual model as well.
Thank you. And then we've also got an interesting question, which is that both Kiran's presentation and your presentation have focused mainly on city and urban areas. I'm just wondering if you could kind of take this approach and think about, are there any issues that you think might emerge specific to rural communities that might need to be considered?
Yeah, so I'm having a conversation later this week with the Rutland inequalities representatives, and one of the things that I'm going to be asking them is how can we make sure that we have captured the needs of rural communities when the vast majority of our time is spent within the urban context. But a good example of that is the digital exclusion conversation. So I only became aware of the problem around having some of the poorest broadband speeds nationally in Rutland through a chance conversation. And I think there is a duty on us to be more proactive about understanding the population. So using that census data and then working with academic partners. So the work that we've done through the census has been through our academic partners. It hasn't been through us as a trust, but it's developing that partnership working, because it would be remiss of us to think that we could do it all. I think there will certainly be conversations that are unique to rural communities that we aren't cited to, but we have a duty to be going out there and proactively asking questions.
Thank you, and I hope, Jane, that's answered your question there. Okay, I am going to see if there are anyone else with a hand raised. I can't see any, but I'm just going to ask colleagues to flag to me if there are. If not, I'm going to broaden. No hands. Okay, I'm going to broaden this conversation out now to include Kiran as well. And I think the one thing I just want to focus in on for both of you, which is a theme that has come out for me, which is, you touched on in the answer to the last question, Ruw, is around this whole issue of digital, because it feels to me that we've been treating digital as like this, it's like, this is the key to transformation and this is the way we're going to it will change everything. But it's quite clear, isn't it, that there is never going to be a single silver bullet, and we have seen those elements of, building in another level of exclusion. And I just wonder your thoughts around how we overcome that or how we navigate, not how we overcome it, but how we navigate that element. I'd be interested in your thoughts on this, both of you. Perhaps I'll go to Kiran first, as you've just been talking, Ruw.
Yeah, thanks, Saffron. And it's clear the world ahead is littered with digital and technological advance, isn't it? But I think if digital is a solution, my response is often a solution to what? And I think you've got to say, what is it that's driving inequity in terms of what we're seeing? And we need to dive into why that is happening. So, Ruw portrays a fantastic approach to DNAs. And actually, when you find out why patients don't attend their appointments, it's often because we make assumptions that don't meet the needs of the populations that we serve. In the same way, when we develop focus groups with patients, we often build them at 9 to 5, Monday to Friday. Actually, that doesn't work for people who work nights, for example. And if you look at, the profiling of our populations, even within the health service, our population of workforce looks very different at night to how it looks in the daytime. And we need to ask ourselves why. Then you need to ask about what they need, and then you need to ask how we provide for it.
Thank you. And Ruw, what's your sense on digital?
Yeah, thank you. So I'll just be really honest and say this is probably the bit that I feel most uncomfortable around. It's out of my comfort zone, even more so than data, and the thing that I probably know least about. But I had a very helpful conversation recently, which started with, when we talk about digital inclusion, are we sure that we're all talking about the same thing? And so actually, I think some simplicity around the language, and it goes back to Kiran's point, what is it that we think the problem is with digital inclusion, exclusion, or however we're going to frame it? And then understanding the difference between the inclusion, the exclusion, and then digital capital, which is having the resource to engage with the digital solution. And somebody has put something in the chat around PCs and laptops, how to raise a hand. So even on this call, we have individuals who are asking questions about how do we interact and use this interface. And what we're going out to populations who aren't currently able to access healthcare and expecting them to have the knowledge as well as the capability and the technology to use the solutions we're proposing. And it's exactly what I've described. For some people, that will be part of the solution, but they have to tell us that. We cannot suppose that. And if we do suppose it, we have to go to them with an open mind about learning how have we used that solution and what do we need to do to make it more approachable. But for me, it starts with the language, really, around what is it that we're talking about and how do we use that to create solutions.
Thank you so much. I think there's a lot more for us to dig into on that one as well. I'm just going to ask the team if there are any raised hands.
No hands, but there's a couple of questions in the chat.
Yeah, okay. So I'm going to take the chat questions. So I think there's been some, we've talked, both of you have talked extensively around data, and it clearly is, it's, I don't want to say data is king, but it's clearly fundamental to both of the approaches that you're taking. Someone's asked how reliable, it's Khadija Begum has asked, Jessica Armstrong has asked how reliable is local data on ethnicity? How much do you trust that data? Is it proving to be working for you? Ruw, what's your sense on that one?
Thank you. It's a really important question. So we did a little bit of work around this to test our ethnicity coding. We are assured that within secondary care, our ethnicity coding that we have access to is reliable, is consistent. I think the challenge for me is that communication between secondary care and then primary care and community services. So going beyond our organisation. And that isn't a criticism of primary care, it is more a criticism of how we're communicating with each other and ensuring that data is shared and then recorded. But internally within UHL, we have tested it, and we think roughly, so 95% of our coding we are happy with being accurate and consistent.
Excellent. And Kiran, what's your take on that?
Yeah, I'd agree with Ruw. I think in secondary care, for the patients who get to us, coding is very good if you make an active effort to make sure you capture that data. But if you don't make the active effort, then it's poor, and we see that in some places. But in primary care, I think it's more wanting because it's not mandated. And if you compare ourselves to a supermarket, who gets loyalty cards, actually they know everything about you, so they target the services that we provide. Actually, in healthcare, we don't do that. So how on earth can you have an active strategy to tackle health inequality if you don't know about the equality of your population and the demography that one serves? So I think it's really challenging, and it leads to really challenging situations like primary care access, where people have to call at 8 o'clock in the morning for an appointment, and at the end of the line is a chatbot that speaks in English. Actually, if you don't speak English, you're not going to get in. As simple as that. So we've got to know about the population we serve with good coding in order to have tailored services for them.
Thank you. We've got a question on screen from Lizzie. Lizzie, do you want to ask your question?
Thanks. Yeah, no, I was curious to hear about the networks that you've been developing and the work that you've been doing with your research and academic partners to better understand the census data that's particular to your locality. Because I'm just mindful that for lots of voluntary sector organisations and organisations in the not-for-profit sector, we make lots of demands on them. And this is yet another demand, and how best do we help them to help us? And I wondered if you had any experience that you might like to share.
That's for me, is it, Lizzie?
We'll go to both of you actually on this one, but
yeah,
go for you first.
Sorry. So yes. So from our perspective, I fully agree with the statement around voluntary and not-for-profit organisations and the demand that we place on their time. So if I just give you an example, so the Pursuing Equity programme that we're a part of, one of the learning points to come home with was what is the historical context of the relationship of the population that you serve with healthcare. And there is no way that we as a healthcare provider can answer that question in any rigorous way. So what we've done is reach out to the University of Leicester, to the medical school and the social sciences school, and ask for any support with pulling this together from an academic perspective. And what I have consistently found over the past 8 months is that research is a really great place to start. First of all, for people who are willing, so getting the coalition of the willing, but then also access to funding, and it's not recurrent, but it gets things going in the right direction. The conversation that I had this morning with the charity that I mentioned during the talk was exactly it was a two-way conversation about what I can offer you, but what I need from you is, in this instance, engagement around how do we access cancer services. And so I think the first place for me is to start with recognizing that we are asking for something, and we know we're asking for something, but the potential for us to work together, and the aim is very clear from the outset, is to improve the service that we're providing, and then to draw on others who are willing and able to support us in a more expert way when we're not able to do it for ourselves. I hope that goes some way to answering your question.
I'm on mute. Kieran, could I ask the same question of you? To what extent have you found your work has kind of really tapped into local voluntary and community sector organisations, and how have you navigated that?
Yeah, so probably in two ways, Saffron. The first was the Ipsos work, where we used Ipsos because they're a validated and experienced unit in terms of interacting with third sector and population groups. So we used their expertise. It wasn't cheap, but I think it was important to do it. Otherwise, we wouldn't have been trusted, because people would have just said, oh, well, you would say that it works, wouldn't you? Or you would say the population thinks it's okay, wouldn't you? So we had to fund Ipsos to do that work, which was important. And they published a report, which was then putting it in writing for people to access. So that was important. And then in terms of the research element, we have a health equity and social care research unit, which is looking at the data to prove that actually what we're doing is scientifically valid as well, because that then brings on the clinical and managerial community of the NHS, who quite rightly are saying, actually, give us the proof that what you're doing has an impact in terms of health inequalities. So we had to produce the charts like the one I showed you for orthopedics in terms of access inequity. So you've got to have objective data sets for people to look at, otherwise it's just another pilot, and it will fall by the wayside rather than be sustainable.
Thank you. Are there any more questions from the virtual floor? If not, I'm going to ask another, which is, I've been struck by we've talked a lot about data, and we've talked, obviously, the whole theme of this worked around health inequalities and race inequality in particular, and the focus, the implied focus actually on prevention as well, and those links into kind of public health and those models and approaches. And I wondered to what extent, kind of each of you being in organisations which are part of systems, to what extent do you think the learning from your work is able to kind of feed upstream and influence what local authorities might be doing with their public health work and their public health grant? I'm just kind of trying to get a feel for a sense of if this is bedding into the system as well. I'd be really interested in any thoughts on that from either of you, whoever wants to go first.
Yeah, I'll go first while Ruw thinks of her wisdom. But I guess as a board level inequalities accountable officer, we have a wider strategy, and within that strategy there's the question of what is it that the acute provider can do. So that's why we did the work which is purely acute sector driven. But of course, one thing I did in the middle of the pandemic was appoint a public health consultant, which people thought was bizarre and barking, and they thought I'd lost the plot. But actually I did that so that we integrated across the system and we started talking about prevention. And having that link of a public health consultant into the local authority and the wider system means that we make all of those programs at a public health level meaningful for the population we serve, and vice versa. They inform what we should be doing for patients. I'll give you a little example. Cardiac rehabilitation. We don't just provide it for the patient now. Actually, all the information goes to the wider family as well. Because if you live under the same roof, you'll have the same risk factors. It just so happens one of the individuals has had a heart attack. So actually you can start to integrate in both directions if we work smarter as wider healthcare systems. So I think it's a real positive when we integrate.
Thank you. And Ruw.
Yeah, it's such an important question. Without any shadow of a doubt, we have a role to play in bringing the conversation to as many different fora as we can. And I think what Kiran's really nicely articulated is that two-way relationship that we've got to start to develop between the space that we occupy, whoever we are and wherever we are, and then the wider system. So I fully agree with what Kiran said about recognizing that, so I operate within an acute care provider sphere and lens, but my influence extends beyond that. So if I give you an example from our system. So I'm employed at board level to be the SRO for our approach to health equality at University Hospitals of Leicester Trust. But I also report into our Integrated Care Board Health Equity Committee, and I have a very close working relationship with the SRO for LLR ICB. But beyond that, we have the health and wellbeing boards, and we have the health and wellbeing partnerships. And a really powerful example that came out of our collaborative working more recently has been around housing. So we've been doing some work with public health and inclusion healthcare consultants around service access to our urgent and emergency care services, recognizing that we probably need a multidisciplinary approach to people who are using our services more than they might be if they had a holistic approach to healthcare. This came up at the Health and Wellbeing Partnership, and then actually what we had was a representative from the City Council around housing asking, how can we work together to make sure that the same group of people who we're both talking about, we have a joined up approach to delivering healthcare and other care for. And so we've got a growing group that meets to discuss the challenges. And it's difficult, isn't it? Because we can't demonstrate rapid change and rapid improvement necessarily in something that is as difficult as homelessness, complex multimorbidity, and frailty. But what we can do is start to bring like-minded people into the room so that we're talking from the same page. So I think without any shadow of a doubt, I operate within the sphere that I operate in, which is acute care, but it's then recognizing that actually that's one piece of the puzzle and influencing outside of that and being receptive to the ask of my organization and being open-minded to that, to say, what is it that we could be doing better as well?
Thank you so much. That it's just really helpful to hear. And I just feel this sense of, given that we're kind of grasping this agenda now with, you know, in a way, I suppose, I think you said it yourself, Kiran, that, you know, there's this sense of COVID has really sped up our focus on this in a way. It feels really important that we also consolidate those opportunities that exist beyond the trust only. We've got time for one final question, and I think Alison Davis has her hand raised. Alison.
Thank you very much. Thanks. Yeah, I'm over in Milton Keynes. Thank you for all that. Is really, really interesting. I suppose just going back to one point where we're talking about, you know, working with communities and groups at their own pace, which I absolutely think is spot on. But equally, sometimes, and I'm thinking particularly of our maternity services and things like that, where it's absolutely critical, you know, we see people from early on and, you know, can avoid some very significant health challenges later on. Whether you've got any sort of experience or examples where you've been able to perhaps, you know, working together, get the pace up a bit so that, you know, you can start making these very important points and contact to improve those health outcomes.
Ruw, I'm going to go to you first in terms of pace and varying pace, and then I'll come to you, Kiran.
Thank you. It's a really tricky question. I think the short answer and the honest answer, Alison, is no. So we recognise that whatever has happened to date has clearly not been enough. A huge amount of work has happened to date, a huge amount of engagement, and I think it's credit to the colleagues who have engaged with it, because it is a really challenging space to operate in. I think what we're going to see over the next 6 to 12 months, certainly within LLR, is a way of doing this and a different approach to how do we use this information. Because I think what we're starting to see is data fatigue. So people are hearing about the data consistently, but we're not showing any change. And so the specific aim of our Pursuing Equity project is to reduce late bookings for Black and Asian women at our maternity services by 20% by March 2024. So we're right at the beginning of that journey. I'll be very happy to come back or stay in touch and update you on how we're going to do that. But the short answer to your question is we haven't seen any steady improvement recently or in recent years.
Thanks, Ruw. And Kiran.
Yeah, thanks. And no, listen, maternity is a really worrying set of data, isn't it? Because we are seeing the same differentials with respect to ethnicity that we've seen for many, many years, and we're not improving it. And in fact, the data is even more stark in America, isn't it? I don't profess to be an expert, but one thing we talked about earlier was ethnic recording. And if we don't do that comprehensively in primary care, how on earth can we target those young women to make sure that they need to book early and to access healthcare early? And that is likely to lead to the late booking and the late presentations, and the fact that, you know, for an Afro-Caribbean young mother, we don't measure her blood pressure until she's probably at 25, 30 weeks into pregnancy and possibly preeclamptic. So our systems are set up to ignore people. They're not set up to identify people. And I don't say that lightly. And likewise, if we look at the data that we then submit, we're very good at being reactive. So the data sets to embrace when we have a perinatal death or a maternal death are really comprehensive, and they're fantastic, but it's too late. They've died. Okay, so we're great at being reactive and forensic, but actually what we're not good at doing is being proactive to get that data upstream and use it to influence and shape the healthcare services that we need. And very recently, I was gobsmacked when I looked at our maternity board report. to find that we didn't have ethnicity that featured in the perinatal death analysis. And I went back and said, let's do it. And of course, the guys did it. And about a quarter of the deaths were from an ethnic background. And I said, right, so this is worrying because less than a quarter of our births are from an ethnic background. And it's asking those sorts of incisive questions that we should be doing at board level and at specialty level every day. That makes it necessary for us to open our eyes to what we're not doing and who we're ignoring. Because, you know, what we shouldn't do is design a service based upon being good at being reactive.
Thank you so much, Kiran, and that feels like such actually a really important point to end on, really, which is, you know, making sure that we're really clear about who we're ignoring as well as who we're treating. And that, I think that takes us right to the beginning of your presentation, in fact, Kiran. We are going to draw this to a close now. I think it's been a really rich and fascinating conversation, and thank you to both of our speakers for their contributions, and thank you to the questions both in the chat and from the floor. I've been really struck by the focus here on the importance of kind of proving the approach, demonstrating how it works, and then broadening that out to other areas and sharing the learning. I think there's something very important about data here. Data is king, but we've got to avoid that fatigue, but keep on using the data. Digital seems to be a problematic issue, and we shouldn't be kind of get overwhelmed by the sense that digital will solve all of our problems. We need to focus on the problems themselves rather than digital as a solution. And then in particular, I've been struck by this notion of pace and how you need to go at the right pace in order to engage the communities that you want to engage with as effectively as possible. So I am going to draw it to a close. Thank you to our speakers. Thank you to all of you. We've got more events coming up. We've also got, you can scan the QR code to see those, and there's a link in the chat to book onto upcoming events. We've also got an evaluation form which has just come up. You can scan that slide right now to get the evaluation, and if you could fill that in, that would be immensely helpful to us. For us, it's really important that we know what you think so we can improve our events as we go forward. But with that, I'm going to draw it to a close and say thank you all very much for your time and your contributions today. Thank you.